عشان الوقت متاخر، والزميله العزيزه الاستاذه الدكتوره إلهام حسني هتقدم السكند سبيكر. اتفضلي يا دكتوره إلهام.
الحقيقه انا بيسعدني جدا ان اشارك في الندوه دي اللي قام بتنظيمها تماما زمايلنا الاصغر سنا في الوحده. فده شيء اسعدني جدا ان هم كبروا وابتدوا هم بنفسهم يعملوا ندوات في الوحده وفي الجمعيه اللي اسسهم استاذنا الغالي الدكتور يحيى جمل. كنت اتمنى انه يكون موجود النهارده عشان يشوف مجهود بناته واولاده في الوحده. انا دلوقتي ليا الشرف اني اقدم النجم الساطع في سماء الالرجي ايمينولوجي اند روماتولوجي الاستاذه الدكتوره داليا الغنيمي، اللي النهارده الحقيقه شايله بيردن جامد جدا في الوحده وفي الجمعيه ومشرفانا دايما ورافعه راسنا. دكتوره داليا is an active member of SPI, and she's a member of the World Allergy Organization, member of the Pediatric Rheumatology European Association اللي هي البريس، and the Pediatric Rheumatology International Trials Organization اللي هي البرينتو. دكتورة داليا النهارده محضره لنا موضوع جميل قوي حسب ما اتوقع ان شاء الله عن الرول of primary care physician in pediatric rheumatology. اتفضلي يا دكتورة داليا.
شكرا لحضرتك جدا دكتورة إلهام، وشكرا اساتذتي وزملائي جميعا يعني على حضور ومشاركتنا الندوة دي، وإن شاء الله يا رب يبقى علم ينتفع بها وتبقى لطيفة كمان بإذن الله. بسم الله الرحمن الرحيم.
افتحي فول سكرين يا دكتورة داليا.
أنا المحاضرة زي ما الدكتورة إلهام تفضل. أنا فاتحاها حضرتك. أنا عاملاها
هي دلوقتي فول سكرين يا دكتورة داليا.
النهارده إن شاء الله تبقى المحاضرة زي ما الدكتورة إلهام تفضلت قالت على إنها it will be about the role of primary care physician in pediatric rheumatology، عشان this seems to be some sort of zone of confusion who should manage with طيب دور الجنرال pediatrician or primary care physician in the field of pediatric rheumatology, their exact role what would be in this field. The objectives of my lecture will be to emphasize the role of primary care physician in pediatric rheumatology through the following scopes. How can the primary care physician or the general pediatrician help in early diagnosis of pediatric rheumatic disease? Second, how far the appropriate interpretation of the routine and immunological laboratory test is crucial for timely proper diagnosis. And lastly, the management plan of pediatric patients with rheumatic disease. So starting with the first scope, how can the primary care physician or the general pediatricians help the pediatric rheumatologist to reach the early diagnosis of pediatric patients with rheumatic disease? First, to be aware of the common clinical presentation of rheumatic disease and the differential diagnosis, most importantly, infections and malignancy. أنا مش هدخل في الحتة دي لأن أستاذي دكتور أشرف تفضل مشكور ب يعني شرحها و give very much informative and concise report about it. تاني حاجة to request the essential investigation and third the timely referral to pediatric rheumatologist. So what about the field of requesting the essential investigations? إحنا all the pediatric rheumatologists know quite well that there is a huge battery of immunological laboratory investigations needed to determine the exact diagnosis and the extent of the organ involvement in childhood rheumatic diseases. But for the general pediatricians or the primary care physician, we need to ask for and to emphasize on the time and the cost effectiveness to order the only essential investigations. So it is divided into the routine laboratory test and the immunological laboratory test. For the routine laboratory test, every patient with suspected rheumatic disease should have complete blood picture with differential leukocytic count and reticulocytic count, acute phase proteins, which is the ESR and CRB with TIT, and the metabolic profile describing the kidney function, serum creatinine, blood urea nitrogen, and the liver functions, and total bilirubin. Direct bilirubins are mainly to see if this patient is presented with anemia, the type of this anemia, could it be hemolytic anemia or not. Serum albumin and LDH, it is important to also emphasize whether there is ongoing hemolytic anemia, or it might direct the attention of the general pediatrician and the primary care physician to be another underlying disorder if the investigations are not consistent with a picture of rheumatic disease. Complete urine analysis, protein creatinine ratio is ordered only if there is normal glomerular filtration rate. For the immunological laboratory workup, it is concerned mainly of the anti-nuclear antibody titer, anti-double-stranded DNA antibody titer, complements 3 and 4, direct and indirect Coombs test, antiphospholipid antibodies, anti-neutrophil cytoplasmic antibodies. Why these antibodies are specifically chosen? Because these antibodies are involved in the diagnostic classification criteria for systemic lupus, and anti-neutrophil cytoplasmic antibodies for the predominantly small vessel vasculitis, which is the ANCA-associated vasculitis, like what's formerly known as Wagner, which is now changed its name to granulomatosis with polyangiitis. Direct and indirect Coombs test both involved in the classification criteria for systemic lupus, and as well, if this patient is presented with hemolytic anemia, it will help to direct whether this patient has autoimmune hemolytic anemia, or it might be a picture of microangiopathic hemolytic anemia. Imaging studies, we refer to this patient if it is emergency case, yani patient presented with heart failure, we need an echo, patient suspected to have Kawasaki, patient presented with hemiplegia, convulsion. So this is an acute presentation. Sometimes if the patients have some sort of arthritis, and you need to know whether it is, it could be some sort of synovial thickening, and it is a chronic arthritis or something else, so with masses or any other abnormality, so ultrasound of the joints will help to refer to the pediatric rheumatologist. Then, to reach early diagnosis of these patients, we need timely communication with the pediatric rheumatologist. In emergency case, and there is lack of feasibility to timely referral to a tertiary center with a multidisciplinary team, so we need to do proper communication with the pediatric rheumatologist to allow for consultation about further investigation, and to allow initiation of treatment as appropriate for this critical presentation. So what about if the case is stable? So please allow for proper arrangement to refer this patient with appropriate appointment to the pediatric rheumatologist at tertiary care center, or if it is at the level of the community. So starting, who is the pediatric rheumatologist? To reach a pediatric rheumatologist, which accreditation and training you need? First, you have to receive a solid basic training of general pediatrics for a minimum of 3 years duration. Then to have training at clinical and academic aspect of pediatric rheumatology at tertiary care center, a minimum of 2 years duration. And academic means that you are involved in, you have training in teaching aspects of pediatric rheumatology and involved in research. Clinical and academic, then to reach a pediatric rheumatologist, so you have to practice clinical and academic aspects of pediatric rheumatology and provide an adequate communication with other specialties, relevant specialties involved in this field of childhood rheumatic disease for a minimum of 2 years duration. We don't want to make things sophisticated, but we see, and مش إحنا بس, it's worldwide that a communication with a pediatric rheumatologist should be in children presenting with a disorder suspected to be a rheumatic disease. Why? Because general pediatricians have much to know about many diseases. It is very difficult to be competent in all subspecialties and to know all the updates about different fields of disorders in pediatrics. Adult rheumatology are actually internists and have limited training in caring for children and adolescents with rheumatic diseases. Moreover, there are also multiple pediatric issues that internists tend to have limited understanding, such as dosing and the choices of anti-rheumatic drugs. Also, many rheumatic diseases have different presentation in children than in adults, like Kawasaki, like systemic GIA. So if certain district, place, country, they have limited subspecialty of pediatric rheumatology, limited number of these specialists. So there must be a very good communication between the adult and the pediatric rheumatologist to provide these patients with the best care. Second, concerning the role of the primary care physician is the appropriate interpretation of the routine and immunological laboratory tests. This is very crucial because some colleagues consider that a negative test or certain negative immunological test can exclude the disease and vice versa. If it is positive, then it is the disease which is not true. So, and all tests should be interpreted in the context of clinical presentation. So starting with the routine laboratory workup, complete blood picture is very important to be very cautiously interpreted. So if you have pursued a simple diagnosis of systemic GIA, systemic vasculitis like polyarteritis nodosa, granulomatosis with polyangiitis, familial Mediterranean fever, mevalonate kinase deficiency as a part of the autoinflammatory disease, you have to revise these diagnoses if you have normal values of leukocytes and platelets or cytopenia. This are against a simple diagnosis of this disorder because these disorders are typically associated with leukocytosis and thrombocytosis. So the possibilities whether the diagnosis is correct, but it is severe case and the condition is complicated with a life-threatening complication of macrophage activation syndrome. This is a very life-threatening and need prompt diagnosis and intervention. If the diagnosis is correct, then it has a panel of investigation to be verified whether there is underlying macrophage activation syndrome or not, and this should be through communication with the pediatric rheumatologist. Another underlying disease. Therefore, revise the diagnosis, and cytopenias is indication for a bone marrow examination. Okay, if we have cytopenia, should not be overlooked in a patient with systemic lupus as well. So the possibilities taking consideration as well the clinical presentation, whether the patient is somehow third general condition or stable, or there is no emergency presentation. It may be immune-mediated peripheral destruction. The anemia could be autoimmune hemolytic anemia, or it could be the life-threatening macrophage activation syndrome, or the otherwise severe complication of SLE, which is secondary thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, and this patient would have other features of renal impairment, and in TTP there will be CNS involvement. So coming to the acute phase proteins, ESR and CRP, normal values or slightly elevated ESR do not exclude the diagnosis of some rheumatic diseases such as oligoarticular GIA, sarcoidosis, early disease, PASID disease, so in mild cases of PASID, or even in the CNS involvement and neuropathic disease is very common among pediatrics, and mild case of SLE, if it could be presented just with slightly elevated ESR if it is just linked to the constitutional and musculoskeletal involvement, which is honestly very rare in childhood. SLE in pediatrics tend to be more severe course than in the adult, especially with the renal involvement. So elevated CRP in SLE indicate any of these possibilities. On the top, infections, serositis, like pericarditis, arthritis, or life-threatening macrophage activation syndrome. If we found that a patient with low ESR and clinically active disease is not improving, لكن عنده low ESR, خلاص, is a very ominous sign. This is highly suggests that this patient is developing macrophage activation syndrome. And this is a life-threatening condition. It is a cytokine storm. Serum amyloid A is another acute phase protein, and it is important. However, in clinical practice, it is not routinely used to monitor the acute phase response. It is expensive as well, although it takes a very famous repetition to the FMF, but it is as well elevated in mevalonic kinase deficiency and in systemic GIA. So therefore, a specific indication for its periodic measurement is in FMF patients if they were found at their initial assessment that they have with regular follow-up a chronic elevation of serum amyloid A, even in between the episodes of activity. يعني لو العيان عنده recurrent episodes of FMF activity, and during in between the attacks, the patient is monitored and found to have that persistently elevated serum amyloid A. This is very important to be periodically evaluated because this patient is at risk for secondary amyloidose, which is largely composed of serum amyloid A, and all patients, unfortunately, with secondary amyloidosis complicating FMF, at our experience at our center, they end with death. So coming to the immunological laboratory work of the anti-nuclear antibody titer, it is a large group of autoantibodies that recognize cellular antigen, although predominantly found in the cell nucleus, but it is not always the case. It is associated with many autoimmune disease, but most importantly systemic lupus. مهمة هنا واحنا بنطلب التحليل، عشان انا عندي عيان سسبكتد عنده ماليز، عنده مالر راش، وطلبنا منه ANA الانتي نيوكلير انتي بودي، لازم يطلب والستر، ولازم نبص على الميثود اوف اساي. الموست ريلايبل والموست سنسيتيف الاندايركت immunofluorescence. هي بتستخدم cultured human epithelial cell from laryngeal carcinoma, and the titer is 1/80. لو لقيت العيان التحليل معمول بإلايزا أو other like المالتيبلكس feed based assay، يعني ده مش كمان عندنا الإلايزا اللي أكتر، ده not recommended to consider if you have the test as ANA negative, okay, to be taken as reliable results لأنه of low sensitivity. زي الانdirect immunofluorescence. يبقى طالما أنا initially بعمل screening للعيان and I want to reach whether he or she fulfilled the classification, the immunological classification criteria for SLE، يبقى نختار الانdirect immunofluorescence assay مش الإلايزا. الانتي stranded antibodies they have short انهم يبقوا high avidity anti-double stranded DNA antibodies. They have high specificity for the SLE, and moreover the level fluctuate with the disease activity rising during flares. Well, most reliable methods are radioimmunoassay and immunofluorescence using parasite Clistidia leucelli. ليه؟ لأنها contain only double-stranded DNA. طب الإلايزا detect low avidity. طب أوكي ممكن أستخدمها for follow up، لكن الشرط إنه عشان أعتبره positive to consider it a positive results is a value above twice the laboratory reference range. يبقى في هنا certain precautions or regulations when using test apart from the recommended. Anti-neutrophil cytoplasmic antibodies هم associated with many autoimmune disease, but mainly involved with the ANCA-associated vasculitis or predominantly small vessel vasculitis. They are directed against antigen within the neutrophil granules in the cytoplasm, like proteinase 3, myeloperoxidase, ودولت أشهرهم, elastase and others. And they are مهم جدا ناخد بالنا إنهم serological hallmark of active small vessel vasculitis in granulomatosis with polyangiitis, and the 75% in microscopic polyangiitis is during the active disease, means that their prevalence is much lower during the remission, okay? And moreover, ELR criteria considered إنه this is one of 6 criteria, and its absence does not exclude the disease, خالص. And the titers fluctuate with activity like anti-double-stranded DNA. And they are either immunofluorescence pattern. ممكن هنيجي نلاقي في التحليل كده كاتب لي سي انكا او بي انكا. سي انكا دي بتبقى predominantly cytoplasmic fluorescence, predominantly cytoplasmic, and it is mainly correlated with proteinase 3. While P ANCA against myeloperoxidase would be apart from the cytoplasmic distribution, they have very nuclear fluorescence extension as well. احنا ليه انا ما حطيتش روماتويد فاكتور ناس بيبتايد زي ما هنشوف دلوقتي؟ لان روماتويد فاكتور is not needed ولا الانتي سايكليك citrulinated peptide is not needed to diagnose juvenile idiopathic arthritis. They are rather used to classify the severity of the disease. Rheumatoid factor is not a single antibody, but a group of antibodies directed against FC portion of the immunoglobulin G. مين أكتر واحد reliable to consider the positivity of the rheumatoid factor is the high sensitivity immunoglobulin M rheumatoid factor, and this is associated with increased risk of progressive disease, joint damage, and disability. And in patients with rheumatoid factor positive polyarticular GIA, it is associated with a greater risk for extraarticular disease, mainly interstitial lung disease and subcutaneous nodules. And rheumatoid factor positive polyarticular GIA was some sort they counter for the adult form, but its absence does not exclude GIA. ان احنا بيجي بعض الريبورت لا ما عندوش يا دكتور روماتويد فاكتور يبقى هو ايه ما عندوش جي اي اي. لا. الانتي citrulinated peptide antibodies, the group of antibodies, they are against certain protein epitope of the amino acid protein epitope containing amino acid citrulline. were detected by the ELISA using the synthetic cyclic citrulinated peptide. عشان كده يبقى termed practically anti-cyclic citrulinated peptide antibodies. They are as well associated with severe articular disease, but unlike rheumatoid factor, they are not associated with increased risk of extra-articular disease. Although anti-CCB antibodies have higher specificity for the diagnosis of GIA, but its absence does not exclude the diagnosis. Antiphospholipid antibodies, they are a heterogeneous group of autoantibodies, lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein antibodies, and they are associated with increased risk of thrombosis and certain manifestation of CNS lupus like in Korea with anticardiolipin antibodies. لما اجي احطهم في criteria to diagnose antiphospholipid antibody syndrome, we are the criteria taking moderate to high titer immunoglobulin G and immunoglobulin M of anticardiolipin and anti-beta-2 glycoprotein. And both should be done. يعني لما نعمل anticardiolipin نطلب anti-beta-2 glycoprotein. طب دول داخلين في الكرايتيريا classification criteria for diagnosis of SLE might be affected with the steroids. Moreover, if the patient presented at initial presentation with thrombosis. The lupus anticoagulant is the mostly associated with the highest thrombosis risk. بيعتمد على detection of two phospholipid dependent coagulation assay, either the activated partial thromboplastin time and dilute or dilute Russell Viber venom time. مهم جدا انه لو طلع prolonged assay, any of these two assay, and the more reliable is dilute Russell Viber venom time, that we have mixing assay. يعني يتقال إنه there is no correction when mixed with normal plasma, لأنه ده indicating that there is antibodies to the phospholipid, and it is not just inhibitor to the coagulation factor in the patient plasma. آخر حاجة الرول of the primary care physician أو general pediatrician in the management plan. خلينا نتفق this childhood rheumatic disease or pediatric rheumatic disease لأنها can occur as early as the neonatal period is associated with high risk of mortality and morbidity. وبالتالي وبتعمل burden of the family و cost of the drugs. فلازم يحصل confirmation of diagnosis. There might be a need for extra investigation, and the treatment plan should be very much different from that known, and the choices of the drugs is according to the presentation, according to the patient age, according to the parent preference. So this should be done through a pediatric rheumatologist. And this could occur through the following models of care according to the accessible, لأنه مش كل الأماكن فيها tertiary level hospital. So if there is a place with tertiary hospital with multidisciplinary environment, so the patient is needed to be immediately referred for a pediatric rheumatologist whenever his situation permits this. And I said initially, if he has a critical situation, then we do a timely communication with the pediatric rheumatologist. So if there is accessible pediatric rheumatologist at the community, يعني private clinic أي حاجة يعني أو centers يعني مش tertiary hospital فيها orthopedic وفيها physical medicine وفيها cardiologist وفيها neuro, but there is a pediatric rheumatologist who fulfill the criteria for adequate training and multidisciplinary treatment approach of childhood pediatric rheumatic disease. احنا الأول البلان هتتحط بيه بالبيدياتريك rheumatologist, then هيبقى فيه periodical referral and assessment by the pediatric rheumatologist. At the same time, there will be ongoing regular monitoring by the general pediatrician or the primary care physician. طب in rural or isolated areas, يعني لو مثلا حتة زي حلايب بقى شلاتين حتة بعيدة خالص، اوكي؟ هنتعب بقى هنا، يعني البيدياتريك روماتولوجيست هو المفروض يتعب بقى نفسه شويه ونعمل periodic visits at the outreach clinic. وفي الاوتريتش كلينيك ده لازم يبقى البرايمري كير physicians او لو في general pediatrician يبقى well trained for the musculoskeletal assessment زي ما دكتور اشرف تفضل قال انه في البيدياتريكس to arm و leg و spine ده لازم يبقى well trained عليه. طب لو local hospital ما فيهاش زي مثلا secondary care hospital او primary care hospital ما فيهاش الفاسيلتيز بتاعت التيرشري ليفل، ممكن نعمل telemedicine، يعني linking the patient to pediatric rheumatologist through teleconsultation by general pediatrician, and studies done even at the pediatrics level found that there were no drawbacks on the assessment of the patients and on regular monitoring of these patients. وزي أنا مش هاخد في ده تاني لأن الدكتور أشرف تفضل المشكور قاله. Primary care physician during regular monitoring visits, please kindly to do assessment of the adherence of the patient to drugs, search for the possible adverse effect of the drugs, like and laboratory monitoring for certain DMARDs, disease-modifying anti-rheumatic drugs, whether biological or non-biological, is usually done every 2 weeks for the first month and every 3 months. Assess for any intercurrent infection or acute illness and symptoms suggestive of activity. Any abnormality, please timely communication with pediatric rheumatologist for consultation and to do the proper assessment and for, if needed, timely referral. So it is very important at the end of the presence of networking between pediatric rheumatologists and primary care physician pediatricians to maintain a continuous flow of information, provide continuous medical educations, and monitor the continued care of rheumatic disease patients. At the end, I would like to acknowledge all my professors and colleagues at the Pediatric Allergy, Immunology, and Rheumatology unit. They are very helpful and marvelous in caring for the patients, and I'm considered myself blessed to be one member of Pediatric Allergy, Immunology, and Rheumatology unit. And at the end, thank you so much, and please remember that early diagnosis and treatment change lives of these patients. Thank you.
الحقيقة thank you Professor Dalia. We are blessed to have you among us, all the members of the pair unit. وأنا I'm really يعني enchanted بالtwo lecture يعني
فعلا بنشكرك جدا يا دكتورة داليا. البرزنتيشن كانت very comprehensive and informative و very practical، لأنك اديتي فعلا المعلومات بطريقة مبسطة ولطيفة جدا